Hello, and welcome to another episode of Cutting Edge Health and how we help you punch pain in the face, whether it's physical or mental, and help you get back to leading the life you deserve. Today, we're going to talk about a very famous study, which now is almost close to 20 years old, but many people haven't heard of before. And it's called the STAR-D study. And it helps people understand about the aspect of using science to be able to treat depression in the real world. It looks at a large number of patients, about 4,000 patients in totality, and it looks at what happens when you try a medication and that medication doesn't work and what you can do going forth from there. If we haven't met, I'm Dr. Orlando Laringem. I help patients understand how to be able to improve their pain and how to be able to punch pain in the face and get back to leading the life they deserve. Today, we're going to look at a study and we're going to kind of give insight about what that study means by breaking it down so you can have some insight. So one of the things that we want to do is to take a look at this study and say, okay, how can we be able to assess this and understand it a little bit better? So the STAR-D study, exactly what is that and what does it mean and how do we interpret that so that we can understand things a little bit better? So as we kind of take a look at this paper, one of the things that we can see is that STAR-D stands for the following. It stands for Sequenced Treatment Alternatives to Relieve Depression. So that's a mouthful, and I get that it's a mouthful, but in essence, what it's talking about is how to be able to utilize a study that lets you be able to see and assess how to know when to start and when to go back and forth with using medications in order to be able to get improvement. All right, so when we take a look, one of the things that it talks about is it took these number of patients and it wanted to figure out how to be able to help get the best improvement for depression. As we know, depression affects quite a large degree of the population, anywhere from 10 to 15% of the US population, and it is most prominent from ages 15 to 44, but can also occur obviously much older than that. This study looked at people that were from 18 to 75 years of age who had a major depressive identified by a clinician, and they had an appropriate score that was rated on something that's called the Hamilton Rating Scale for Depression, which normally that score was looking at something of at least 14 on a 17 item. So why is any of this important? Well, the reason why it's important is because patients really get very dejected when you try a medication and it doesn't seem to work and they don't know like what the heck is going on and what are we doing. So that's why we're talking about this in this video. Approximately about 30% of patients that try an initial medication will have success. But many times that's not told to patients. They're not explained that when we take a look at being able to try to be able to improve patients, that 30% of patients are going to get success, but that other 70% are not, right? This particular article that we're looking at is kind of a review that looked at the aspect of primary care physicians and how they treat depression quite as frequently as what psychiatrists sometimes do. And this initial study looked at a medication that's Celexa that was utilized initially, and it was then transitioned over to other medications if it wasn't successful. So you can see the initial medication was utilized, and then it was either augmented by having an additional medication that was in place, or it was transitioned to a different medicine. And then from there, it was transitioned to a different medicine and transitioned to a different medicine. And so we're going to kind of jump through some of that because that can get a little bit onerous as we kind of like talk about this and the algorithm and all these type of things. But at the end of the day, one of the things that they found, as you can kind of see over here in this green little sort of column here, it states that they cannot tell us if adding another drug is better than switching, and really is at the discretion of a patient. So many times people would say, well, what about cognitive therapy? And one of the things that they found is that fewer patients accepted cognitive therapy as a randomization option. For the most part, it was something that didn't make things worse, but in terms of being able to give as quick of a response, it traditionally did not do that from what we saw in the context of the study. All right. One of the things that we have also been able to assess was the utility of who were the sites that really looked at this. So who were the sites that conducted this? Well, actually, it was pretty numerous and some pretty heavy hitters, as a matter of fact. And so what we saw were the following. The individuals that were present were, or rather, the entities were Mass General Hospital, University of North Carolina, University of Texas at Southwestern, the Clinical Research Institute at Kansas, University of Michigan, Northwestern, New York State Psychiatric Institute, University of Pittsburgh, University of California at San Diego, Laureate Psychiatric Hospital and Clinic, Oklahoma Tuscaloosa VA Medical Center, University of California at Los Angeles, Vanderbilt, and Virginia Commonwealth University. So as you can kind of see, taking a look at all these different universities, this was not something that was a small entity that was just like, oh, wham, bam, ma'am, no big deal. It was a $35 million study, and it was conducted over 6 years. And in evaluating that, it really was pretty challenging to be able to say, okay, well, what do we take from this? And it has been kind of disseminated over time to be able to help practitioners understand that there's no quote unquote right answer, but there are certain suggestions as to what makes sense in order to be able to get benefit. A lot of patients will say, well, if you have depression, okay, I get it, but what difference does that make when we talk about how can this benefit me? Well, for those people who have pain, one of the things that you can kind of see is that the STAR-D actually also found that those people who had major depressive disorder, a number of them had pain complaints that were pretty prominent and weren't well studied. And what they found is that the individuals who typically had some of these issues were individuals who were younger, who were African-American or Latino, and their pain complaints were typically associated with anxiousness and irritable mood, or sometimes sympathetic nervous system issues or gastrointestinal issues. And those combinations make for a bit of a challenge because many times we just focus on depression or we just focus on pain, but we don't focus on both. And one of the ways to be able to kind of look at this is what can be able to provide value to both. And so one of the things that we would really kind of be able to take a look at to be able to see what can be able to provide value to both, as we know by looking at certain things such as this, we, as identified previously, is that this little bar graph here shows the cumulative remission rate by treatment level. So as we talked about these different steps, you have remission, meaning so it's an improvement, 30% with the first, somewhere a little bit greater than 50, and then you're kind of getting up to maybe 70% with the fourth try, but that's not always that is not always the case, is maybe we need to look at how to be able to do something a little bit better. And one of the things that we can do to be able to do something a little bit better than just medications alone is actually the utilization of something like TMS. So this is a consensus statement that was put out that looked at repetitive transcranial magnetic stimulation in the treatment of depression. And it looked in, particularly in the context of the aspect of STAR-D data. And so if we scroll past a lot of the context that gets into the full element of kind of breaking down the pieces of TMS, one of the things that they can see is the following, is that, and let's see if we can expand this so it's a little bit easier to say, is since FDA's initial clearance of the device in 2008, TMS has been increasingly incorporated in practice. And a consensus recommendation is that depending on coil placement and selection, all those type of things, is that it can be an effective application that can be useful in treatment of major depressive disorder. And it can certainly be valuable, particularly in the context of those patients who have had challenges with initial response through medication and potentially cognitive behavioral therapy. So what we know, again, to kind of put it in summary, is the STAR-D study looked at those patients that had difficulty with being able to be responsive to a medication for depression. What we were able to see is that sometimes by switching medications and sometimes by adding medicines like another adjunct, you can be able to get benefit. But at the end of the day, what we need to do is to say, let's not just give up with the first. We need to try something different. And for those patients that are getting frustrated with having tried something different, it may be for a number of different reasons, not just the mood, but it might be associated with pain that's working conjointly. And can we be able to help treat that possibly with a non-invasive methodology in addition to the utilization of medication? Something like transcranial magnetic stem may prove to have some degree of value, and possibly may be able to decrease medication and maybe be able to cease it completely. There's a couple of studies that look at that, but we will leave that for another day. Thank you so much for your time, and wishing you all the best, and hoping we can be able to help you understand your options for being able to punch pain in the face and get back to leading the life that you deserve. Thank you so much and have a great day.